Well, good morning, everybody, and welcome back to another interview. My name's Peter Duffy. I'm an ex-NHS consultant surgeon and whistleblower. As usual, we're joined by Helen Hughes, who is the Chief Executive of Patient Safety Learning. We've got Lottie in the background, as usual, and we're very privileged today to have Beatrice Fraenkel join us. So Beatrice has held all sorts of roles around the country, I think it's fair to say. Um, a good number of them non-healthcare, but very notably chair of the Mersey NHS Foundation Trust. So I think you were doing that job for about 14 years, which is a longer tenure than I think a lot of your contemporaries. Is that fair to say?
It's because you start again once you're appointed a foundation trust.
Oh, right. But 14 years is an awfully
It
long
is,
time to last in a position of that sort of responsibility. And I also noted, just Googling you, that you've worked as a CQC inspector and you've held a non-executive director role as well in an NHS Foundation Trust. So it's great to have you here today. And certainly from my point of view, my questions are going to be a little bit skewed towards trying to unpick your perspective from that position, because everybody we've interviewed so far has had a pretty direct role in healthcare whistleblowing, whereas you very much had a responsible sort of overseeing role. So welcome, and thank you for agreeing to appear. And I wondered if we could perhaps start off just asking you if you could help us out a little bit with how the power structure in these big NHS Foundation trusts actually works. So, I noticed Merseycare have an annual budget of in excess of 6 billion. So it's a massive organisation, isn't it? And I think a lot of people like myself don't understand how the power structure works and the interactions between non-executive directors, board members, chairs, chief executives, and so on. So um, if we could start off by asking you about that, I'd be really grateful.
well, Peter, the scale of the trust doesn't matter. The principles are the same in terms of how the organisational structure works for all NHS trusts. And the board of directors is made up of non-executives and the executive team. The non-executive numbers have to be above that of the executive. So by one is absolutely the right balance. But everybody sitting on the board has to carry personal and corporate liability and responsibility for the running and the decision-making of the trust. In foundation trusts, the difference is that we have a board of governors who are elected from different categories of geographical areas and interactions that the trust have. They are absolutely independent of the organisational structure of the trust. They make the appointments to the board for the non-executives and the chair, and they are the group of people who hold that team around the table of the board to account. So that is a really important aspect of governance. Within the board itself, then, the board itself generally will all have audit committees, finance committee, workforce committee, quality committee. They can be described in different ways, but they have terms of reference which are all related to the oversight of different aspects of the trust. But the board itself should be integrated enough and developed to be an integrated board that collectively the total direction and decision making sits. So one of the issues which is quite difficult is, first of all, even a small trust is employing perhaps 6,000 staff nowadays, never mind a massive trust, well, a big trust like Merseycare. And the line of sight from the board, well, that phrase board to ward, in fact, it's board to community, I would like to say, because what we are doing is we're delivering healthcare of different types and sorts, but we are delivering much more than that. We're employers, so we have a duty and responsibility of how we work as an employer. And very often we're employing not just a diverse range of people, but a lot of people from our own local communities who themselves are really important as users of our own services, of which they're also providers. And I think that from my own background, the values that have to be built into understanding that at the board end can be really quite complicated, because it's not what everybody has traditionally expected that line of sight might be. So that you've got, obviously, as a board, have responsibility towards your regulator, really important. And having done CQC inspections many years ago and how it's changing, if you don't tick that box, if I can put it that way, you've got a problem straight away. But you have to also understand at the board that you've got to look at where all your lines of accountability as an organisation flow. And they don't just flow towards your regulator. They don't just, nowadays, it's even more complicated, flow up to the local integrated care board or the region or even the Department of Health. Your real core responsibility is the quality and safety of your care that you're delivering, how you do it, and how you understand your staff need to be supported by you as a really first-class employer over periods of some very great complexity and change.
Mm-hmm.
And how you build all that in has to sit in your communications.
And you talked there about change. You must have witnessed quite a bit of change during your tenure. I suppose I'm going to go a little bit off piste almost straight away here, but your tenure very much lasted. In fact, right in the middle of it, of course, is the mid-staffs issues. So in your position as chair, and I ought to say, we were lucky enough to interview Helene Donnelly, who was the nurse whistleblower at Midstaffs a couple of months or so ago. In your role as chair, what sort of changes did you see come in as a consequence of the Midstaffs issues?
That's a really good question, because I was privileged enough at that time to be invited, a number of us were, to meet with Robert Francis and have a private session with him about his findings. But after that, also with Sir Stephen Moss. And I had particular contact with Stephen, who was brilliant, and was, as you recall, doing the next bit on. And what struck me, because I have to also add, I've got 30 years experience as a local authority councillor in Liverpool. So I understand an awful lot more about the workings and natures of communities, apart from anything to do with my own sort of other work. And I recall him telling me that he was really surprised and shocked how the local community had turned on Julie, and everything that was, from, let's say, one perspective, regarded as really good, going in there, identifying all the problems, started greatly in being supportive, but then the community started to turn and say, but you're doing this to our local hospital. You are calling, are we going to lose our hospital? And I think an awful lot of those interactions and understandings of the learning have not been picked out because they don't sit into the NHS way of approaching, or hadn't, which is focused on the incidents within the organisation. But what
Yes.
I'm coming at is, and again, forgive me, I'm sure that you and an awful lot of people who end up watching this will know, is as human beings, there are things that are not surprising in people's reactions. But you have to take and understand that that is human beings. That's us. And not separate oneself from it. So that the emotional feelings are, in the end, and we see it all the time, the drivers for behaviour. And you can put as much regulation and as much you should doing, you should, you must, absolutely the wrong language, but really ones that engender fear and anxiety.
And we should say Julie is Julie Bailey, isn't it? Who was the person who originally raised concerns about the care, I think, of her mother. And as you say, came under quite a lot of pressure from some elements in the local community.
Can I just
Yes,
pick up on
please,
that,
Helen. Yes.
Peter, because we had the absolute privilege of Sir Stephen Moss being one of our trustees at Patient Safety Learning. Now he's retired from that role, but a man of incredible wisdom, and the insights he shared with us about those emotions, about how the community's turned against Julie and other colleagues, but also how they turned against some of the staff as well,
Yes.
and the vilification of staff going to work of a morning, and having to walk through placards, people with placards shouting, spitting, being hostile to them. So I think you're right. I don't think we talk enough about the emotional consequences of some of the challenges, either for staff or for patients or indeed communities. It's the language of bureaucracy that we focus on often as a system.
So if I could pick that point up and go back to where I have always sat professionally, if we understand how our emotions operate and what triggers them in a positive or negative sense, we're starting in a very different place. And for me, it wasn't at all surprising that there was that reaction within the community. I've seen it in all sorts of situations here. It can be politically, I mean, there are a whole range of things that can happen. But if you are predicting that they could happen, you can at least have a bit of a chance of building in a thinking about how conversations are held and led and how it works. But you can see all the time, you only have to think of our own selves. The more stressed and anxious somebody is, the more their behaviours are regarded as negative, both for themselves and other colleagues. And fear and stress and anxiety are the huge drivers of negative behaviour. And we can see it certainly, I was going to sort of refer to it later, but the staff surveys, which have just been published in general, aggression, violence and bullying, still the really difficult issues at the heart of our staff experience across the country in different proportions, in different ways. But, and I will just refer to the questions I've raised around it in my current trust, is do we understand anything really about the metrics of first where the aggression and violence is taking place, who it's directed towards, and why? And is there anything then at a board perspective or in the executive teams can be done to put in mitigation? Now, I don't know how it's been in your experience, other people's experience, but the data, the analytics of it isn't there. Doesn't mean it can't be there, but people are making emotional assumptions or they're reading in terms of what they've done before. And there is an element of personal experience, the soft intelligence. But when we start to consider what data and what analytics can do to understand what is actually happening, not what we think is happening, we've got some really powerful information to act on.
So how would you set about studying that and drawing out the information that you need?
First of all, I think that I don't know if this is common in all trusts, but I think that the way data is currently collected can identify the area in the hospital where the numbers are sitting. So A&E, for example, not unsurprisingly, has a higher level of potential aggression and violence towards our staff. From a financial point of view, it's costing a trust not to take action because sickness and absenteeism increase, costs of bank staff, agency staff go up. So you've got a financial perspective on this. And at the moment, that financial perspective is probably one of the stronger drivers, right or wrong, in changing how systems can operate. Because that is where all the pressure is currently and increasingly sitting. So to understand what's going on in the relationships is really, really important. The second part is certainly the culture of an organisation, and you'll be aware in Mersey Care, it's under my chairmanship and under Joe Rafferty as our chief executive, the board took a very bold decision at the time to really shift the culture of the organisation. Now, we're going back several years. It was before anybody else was really doing this. And it was set 0 targets, not 98% target of success, but zero aggression and violence. So we built in a huge development program for our staff about being working in a fair and just culture, psychological safety, all those words that are now, I don't want to say fashionable, but where trusts are trying to replicate. But the depth and the time it takes has to be understood before you get any evidence of change. I mean, it's years of work. And I think that you cannot disassociate, you must not disassociate culture, which is a stick of rock. Again, they're words that, you know, are used sort of as part of we are doing, but it's how it operates, where the evidence is that it's working, that is really, really important, because otherwise you don't actually know if the resources you're putting into this development, because it's not cheap, are having an impact on staff behaviour, staff attitude, staff trust. And trust has got to be the fundamental word. In every single case, if you as an employee, doesn't matter which part of the organisation, don't trust your employer, why on earth would you expect what you need to get back from your staff member?
Yes, so that gives us a good perspective.
Peter, that
yes,
is an excellent segue into what I think you are going to follow up in terms of whistleblowing, freedom to speak up. But if I can be a little indulgent, one of the reflections that we've had at Patient Safety Learning is that in response to the staff survey results, which are consistently troublesome for years now, we publish particularly in relation to whether people feel they are able to raise concerns of clinical concerns, whether they will be listened to, whether they're fearful, and those percentages are pretty much static, and so there's a really big challenge across the system here. My question I had is that the work that you did at Mersey Care, and I followed it a bit, but I haven't followed it as much as I would like, because I don't think there's as much understanding of, you know, the boldness of your decision making, and then what you did. NHS England and other national bodies will talk about organisations need to change their culture, but they don't necessarily say how. They don't necessarily provide people with the tools and the experience. So how do you think organisations should be learning from that across the system? It seems strange to me that there isn't more understanding of what you did, the challenges, the benefits.
It's a really important question, because it goes back to the fact that we are all independent trusts, and that isn't. I know we have the academies and so on, but it doesn't follow that organisations have either the capacity to learn across, or the knowledge that there is something to learn. I was talking yesterday to a chair of a trust up here exactly about this, and about some of the effects of what they're doing on a quite small scale in reducing or in the throughput of patients from their acute beds into nursing homes. And they've done something she was describing as really innovative in collaborative approaches, and the difference it was making to their throughput, so to the patients. And I said, well, you know, can you send me more details? Because I think we all need to know more about this in case it's applicable. But, you know, people don't have either the resources or the time or the energy very often now as well to share. And I think that's getting a really bigger and bigger gap. I think it's always been there, Helen. And I think that there is also the feeling that we either haven't got the financial headroom to invest, because it can take investment. You know, a big problem now, increasing problem, is you can't invest again if you're running at deficit. Yeah. And going back to your point about the staff surveys and the disturbing results, I don't think we're getting an increase either in the numbers of people who are returning their forms, which is also linked to why would we risk? We don't really believe that this is totally confidential, or, oh, well, we do this every year, but what difference does it make? Nothing. There isn't a closing of a circle as a regular process.
And I'm going to go off at a tangent again here, just tapping into your knowledge of sort of executive level stuff. Just in the last few days, sort of locally, without mentioning any names, there is a trust and an inquest that's going on. Bill Kirkup, Dr. Bill Kirkup has been giving evidence and has talked about a culture of extreme defensiveness and so on. And looking at that sort of culture from an executive perspective, how easy is it for somebody in the role of, say, chief executive or chair to create an executive structure around them which is inward looking and defensive, rather than looking at, as you started off by saying at the beginning, looking at the community perspective? Do you think you can effectively surround yourself essentially by yes people, essentially?
Oh, I think that we've got plenty of evidence, not just in the NHS, but in a lot of organisations. And again, in one sense, you could say, well, why wouldn't you want like-minded people around you who you feel comfortable in working with? Because it takes a particular type of person maybe to have that discomfort of being shaken up, of being disrupted. So I don't think it's sort of around, it's just, again, one of those factors. I think.
But it shouldn't be easy, should it? It shouldn't be easy to surround yourself by yes people, because that's how we end up in these sort of situations where organisations don't seem to be held to account. Is that an unfair comment?
I think it's more everybody knows what you're saying is what's supposed to happen, and isn't always aware that that's what they're doing because of the way in which appointments are perhaps made. I think that the role of governors in that, for the non-exec side, for the chair side, is really important. But these days, I think that they are technically making the decision, but they have to take account of the views of other parts of the system now who might be sitting in on interviews such as the region or the local ICB. I think that under certain pressures, it's almost inevitable that people are going to want to have colleagues who they are familiar with, know, trust, and can get on with. And I think, you see, again, it's an interesting reflection, Peter, because you have to have a confidence to have disruption. You have to understand what disruption, if I can use that word, it sounds a bit negative, but it's actually what we're talking about, having that line of sight, that perspective that will cause more stress into the executive system isn't welcome unless it is understood and recognised as being helpful. And I think that that caucus of like-minded people is partly something that we can start to see happening within the staff as well. And certainly I've had a lot of experience seeing the fact, going back to my earlier comments, that colleagues become very, very much part of a self-protective team. And going back to that whole area, which we'll come to, I think, later, around the whistleblowing or freedom to speak up, one of the things that can really does happen is that colleagues don't want to speak out because it's they will first of all be breaking loyalty to their colleagues. And that can be embedded not just in the workplace, but in colleagues' friendships outside the organisation. And that's why I go back to the importance of understanding as an employer, you're employing people from your local communities. You're employing people who are having social and maybe family contacts and community contacts outside their place of work, so that the loyalty to the trust isn't necessarily the first point of loyalty.
Yes, that's right. It's something I've observed again and again and again, is people feel this sense of loyalty to their organisation when really their loyalty ought to be to their patients and to their local community. And I do think that is lost in a lot of NHS Trust and a lot of other healthcare organisations as well. So my next question, I was going to sort of flip it around a little bit now, and we've heard from you, from your experience of executive level culture and so on. So obviously you also have a role in whistleblowing as in your sort of speak up role. So looking at it now from the coalface perspective, if you like, how would you advise somebody who has seen something that they're not happy with, you know, risk-taking, cover-ups, inappropriate behaviour and so on, who is fearful because they know what often happens to whistleblowers? From your sort of executive perspective, how would you set about advising them how to take their concerns forward?
There isn't exactly a simple answer because it depends, doesn't it? We all now have freedom to speak up guardians, and they are the first. If somebody can't speak to their line manager, where do they go next? And if they feel uncomfortable about talking to any of the people around them, in theory and in practice, the freedom to speak up guardian should be the person to whom they have that conversation. And where the freedom to speak up guardian is then the lead and the link for whatever needs to happen next. The way that operates is different in every trust. Some trusts have a number of freedom to speak up guardians and ambassadors who are trained and developed to be those points of contact for staff, and some haven't got the capacity to have perhaps the proportional numbers as the scale of the trust might need. The sign of success, first of all, in that working is that there should be an increasing number of people who want to raise matters and issues. What happens with those is that pathway, it's like the patient pathway, isn't it? You've got to have a route map which is trusted at every single point by everybody, that if their voice is heard, they feel safe, and don't worry that something untoward or unexpected may occur. Also, huge worry about how their own colleagues may respond, going back to those earlier conversations, and understanding that a line manager may need to be involved at some point, and how will that person react and behave? Not what they say, but what actually happens, because that, as you know, can be very, very different. And some of what people are feeling is really complex in how to describe it as far as they're concerned, because it could be something that is really very deep and difficult to talk about. It can be that they are not that certain in what they might have observed or interpreted, and not be clear whether or not it's something that should be raised. But I think that the whole principle of it being of value to not just the individual, but the organisation, the patient, and beyond, is something that absolutely has to sit at the board level and check and test. We get, in my trust, we're getting a quarterly report, and I personally meet every 2 or 3 weeks virtually with our Freedom Speak Up Guardian, and she knows we can work together in a very confidential manner if there's anything that she's not comfortable about. And I think that one of the other aspects is that the trust itself may not know what to do with everything that's raised. And I've had personal experience, and I won't go into more detail, but of a non-exec raising an issue about an appointment, and concerned around bullying and a history of bullying, which wasn't picked up from interview, but was sort of there, and was very gently but firmly told to step back. Now, these are things that are really tricky, because if you're told to step back, however nicely it's done, what do you do?
Yes.
And then the lawyers, you see that the fear of lawyers coming in and the costs. So that these are nuances which we've seen the consequences of not tackling properly, which get out of all proportion to what should have happened at a much earlier stage. But bit by bit, if you understand why it's been allowed to not be dealt with, you get a better understanding of both the culture and what needs to happen within an organisation. But the resources to go through all this are considerable.
And I guess on that point, do you think it is good or bad that Freedom Speak Up guardians are actually directly employed by the trust? Do you think they would be less vulnerable to pressures if they were independently employed?
I think that's a really interesting point. And I think that if they were independently employed, again, it's just having a real clear view about how they would be themselves managed or accountable. Given that nothing's ever going to be perfect, would it be a better system or not? I think would have to be, I don't have a view on it at the moment, without sort of just checking what that independence might actually mean. I think that that confusion between freedom to speak up and whistleblowing, though, is something that really does need to be sorted out.
Well, that was actually going to be one of my next questions, so that's very timely, because I think whistleblowing itself, it can be a difficult term, can't it? Because I was actually I just did an online attendance at a whistleblowing lecture just a couple of days or so ago, and they were talking about the term whistleblowing there and saying it doesn't translate very easily into a lot of other languages. And for a lot of people, whistleblowing conjures up images of people like Ed Snowden or Chelsea Manning, Julian Assange, who they're heroes to a lot of people, but they have given away state secrets, and therefore the whistleblowing label carries sort of contradictory feelings, doesn't it, for a lot of people? Whereas in the health service, it's your job, it's your responsibility. Your regulator can hold you to account if you don't do it. So in that context, do you think whistleblowing is an unhelpful term? Should we be using something else?
I've always disliked it intensely, because as soon as you put somebody into a formal box labeled whistleblower, it transforms everything around it, both legally and in every other way. And what we're talking about is how do we help ourselves and staff and each other improve the quality of care and safety for our patients, and the improved and safe and healthy environment, which is again, psychologically safe for our staff, so that they can give of the best of themselves. And as soon as you start saying, if you do this, then you become A, it's got huge connotations and really, really worrying, because, again, going back to the example of the non-exec that wanted to raise or did raise bullying, that was put as a whistleblowing. And as a consequence, they got a very nicely worded, I've seen it, legal letter from the solicitors, because at that point, the trust itself didn't actually know what to do, because it wasn't a staff member. Now, if it had been a staff member, I'm really curious to wonder how that process might have been taken. Now, it's again power, isn't it? It's about where people perceive and feel power, which can affect them adversely or positively. And what we're talking about is a type of cultural approach where there is, I'm going to say, equity across the whole organisation, so that the trust and the collegiate ability to work supportively one to the other isn't hierarchical. I know we'd spoken quite a lot in early days at Mersey Care, just sort of more privately, around other models like cooperatives. I don't mean that you're going to get no problems there, because we know that's not the case, but that this hierarchical model is actually really controlling. And one of the conversations I'm often having these days is how difficult it is for a board now not to behave in response to the pressure, and you could say that it's quite bullying pressure from the centre, as it's like to be called, because everybody is pushing risk and responsibility down to the next layer. And what starts to happen then is people respond to it in the way that it's placed on them. Now, if we were to see a more collaborative approach to how do we work together in a cultural change, not you should be having this culture in your organisation, but our culture isn't a demonstration of how it should look, that might be a first step.
Can I pick up on that, Peter? Because I'm trying to work out how to frame the question around your professional background as an ergonomist, really, and the impact that's had in your understanding and of your roles in the NHS. And it's often reflected, and there's a better understanding now, I think, in healthcare of this sort of the difference between work as imagined and work as done. And I thought that might be the point to come in and ask you about your perspectives on human factors and ergonomics at the point where you have these intense pressures, maybe outside of the organisation and within the organisation, all pushing those pressures or those risks, as you say, further and further down, right to the very front line, to people like Peter and colleagues who are then having to respond to those. So just wondering if you could give some reflections on that in the context of, you know, human factors and ergonomics thinking.
I think it very simplistically goes back to not assuming you actually know what's going on and taking that reflective oversight in understanding what it is we're trying to achieve with and for our workforce, our communities and our patients, and checking and testing how our processes and systems deliver it or not. I think that the next step of change, which we're starting to see, is around how a different generation choose to be employed, because there are increasing tensions, and it's not just one trust or another, it's in other industries too. What's, I think, the term Generation Z, are making choices about how they choose to be employed, so that where you're starting to then look at your sickness and absenteeism and leaving, the age range is really interesting because people are leaving through retirement, which is expected, but they're also leaving from the younger age group, I think sort of 30 downwards, because they're making lifestyle choices about how that person wants to be employed to keep a balance of mental health and work and family life and other things. And that, I think, with the scale of employment that the NHS is at, is going to be something to start to see where the understanding of their line managers and the behaviours of their line managers is supportive rather than you should, you must, this is how it's always been done. So I think there's another layer of potential risk in not getting something right, because assumptions are made about how things should be, not how people then actually behave or want to behave. The voice of being responded to is really about building trust and closing the circle, that if somebody does have a concern or raise a complaint, that not just but they know that the circle's been closed, not necessarily always to their satisfaction, but the way it's done matters. And if it's something wider, that it's known to colleagues. I will always remember in Mersey Care, one of the earliest things we did when we introduced the fair and just culture and put it out to the staff. There was an incident at Ashworth, which is our high secure hospital, and somebody had been suspended by their line manager, appropriately in the way that they thought they behaved. We were asked to have a review of it, and we reinstated under that system a learning approach. We reinstated the person who'd been suspended. It was actually really timely in that it was an example then to the staff all over that as a board and as an approach, we meant what we had written and said. And you don't often get the chance to demonstrate it, but when you do, it's terribly, terribly important that it's communicated in a way that builds trust. And if you've let somebody down, that you acknowledge it.
Mm-hmm.
Not easy at all.
And coming on to your role in the Freedom to Speak Up sort of movement, if you like, we've heard a fair bit about the sort of negative culture. Have you come across any cases where things have worked properly, where you've ended up with a good, positive result from somebody coming forward and blowing the whistle, for want of a better phrase?
I was reflecting on that question, and yes, there's small bits and pieces which all matter. So the difference between staff being heard and listened to, and that word whistleblowing, is where some of that sits, isn't it? Because if you're listening to your staff on an ongoing basis and responding to them, then putting it into a different category of whistleblowing is where something isn't working. And I was reflecting that lots of examples of staff being heard and being responded to in a positive way. But on the whistleblowing end, the more serious end, I need to check with my own Freedom Speak Up guardian for some examples of that, because things can take so long to go through the processes. And I know that in some of the documentation, there are examples of ongoing inquiries. The other thing, and I really do think this is important to mention, is the ability to do this anonymously. Not everybody will agree with that, but and you can always only perhaps go so far with anonymity, but it's really important that staff do have that opportunity if they want it.
Yeah, I think that's absolutely right. And I would add as well, even with anonymity, it's all too easy, I think, sometimes to work out who the quote anonymous person may be, but it does give another layer of protection for people who are in a very vulnerable position. Helen, was there anything else you wanted to ask? I think we're probably just about used up our time, haven't we?
Well, I was going to follow on that because, I mean, and reflect on your situation, Peter, because speaking up is, you know, we've kind of thinking about frontline staff and their concerns to their line manager, but you had the situation when you were raising concerns as a clinical director, so you were very senior yourself in a role, as I understand it. So
yes, I wasn't clinical director, so but I had done a fair bit of time as clinical lead, and part of the period I was raising concerns, I was the interim joint clinical lead as well, and I was the longest established or longest working consultant in the department. So you would have thought you would have had a degree of protection from retaliation, but it doesn't really work like that. I think when the stakes are high and organizations are in defensive mode, pretty much anybody at any level can be taken down, I think.
Yeah.
And the question that I had, Beatrice, is reflections on that, particularly in the context of increasing demands for there to be regulation of managers, and how that might help, might change behaviours in this context.
I don't know that it would. I think without knowing details of circumstances, because Peter, you're not alone, are you, as a senior whistleblower by any means? It's again understanding what the studies post, and I don't mean Bill Kirkup's brilliant analyses of events, but again from a human point of view, and framing an investigation rather differently to understand the learning from it. Not what went wrong, but how we deliberately understand what we learn. Before mid-staffs, I think I've been around long enough, there was something at Bristol, wasn't there?
Yeah.
And we've got series, and it's not disconnected to a whole series of very big cases. And yet everybody says, oh, we've got to learn lessons. But I suspect very strongly now that the lessons aren't understood to be learned. Because there's a lot of apparent similarity running across it, and denial, always a closing. Certainly, when we took over the Liverpool Community Trust, again, huge problems within that. The inheritance of our staff and the trauma that they had gone through was part of bringing them into the Mersey care fold. But I had been talking to staff for quite a period of time after, and the ability to even talk about it caused a refreshment of trauma. Now, these are not things that are necessarily understood about the very, very deep nature of what can be going on, which if it's not dealt with, never mind if you can't speak about it, you've got major problems, much greater than it looks like on the surface. And it's absolutely no surprise that things like the cases we're seeing, the distress that's not seen through the inquiries to the human being, to the family, the costs, the physical, emotional, and financial cost to not just the individuals and their families, but society and colleagues is mega. And I don't think it's looked at through those lenses. Yes. Now, I think that talking about having qualifications for managers, it's been hovering around quite a long time. You can't, if you're putting solutions to problems you don't understand, you actually don't know what you're doing. You have to be able to have much more clarity about what the potential for something going wrong is because of what you've learned. And the whole thing about putting more regulation in could just be driving it in the opposite direction for all you know.
Yes, I think you're absolutely right about the basic issues with whistleblowing and speaking up not being fully understood. And you mentioned Bristol as well a little earlier. And of course, you can trace the history of whistleblowing in the NHS way back to before Bristol, which happened in the late 1990s, I think, all the way back to the 1960s and the scandals of long-term psychiatric care. And you can see exactly the same sort of trends of sort of suppression of bad news and rubbishing of the whistleblower and so on. So it still seems to me that the NHS hasn't really got to grips with the phenomenon of speaking up and how to properly and positively address issues that concern staff raise.
I think that overriding all is where you've got an organisation who is more concerned about its reputation than anything else, even if it's not fully aware that the damage to the reputation is where people are held back.
Yes, absolutely. And we've heard that from a lot of different people, haven't we, Helen, throughout these interviews? Yeah.
Yeah, it's a consistent theme, and also fear of if you're in that kind of executive role in an organization, that you are under immense pressure from your organization, but externally. Point you've made very well there, Beatrice, and you might not be well equipped to respond in the way positively to a disruptor who's trying to raise concerns, and it may be all about managing the message, the reputation, and some of those behaviours I do think come from fear of what it means to them, their career, their relationship with their families, the communities. It's a very difficult environment to understand, and I don't think we've done enough in healthcare to understand those motives, those behaviours, and what we might need to do to change them.
If you go back to the point, and I think for me that word fear is running fundamentally at every level through everything, because if you're fearful, your response then is absolutely triggered by fear. So fear of loss of status, fear of being perceived as failing in your job, fear of the reputation that you have as a person, fear that you might lose your job. All these are incredibly negative. And I think that that's where a very good non-executive side must understand these factors and understand how to make sure in the trust that you're both protecting your staff, but also learning. And that's where we go back to the no blame and learning culture, because it is the only way that I can think of that I've come across where you're shifting all of those factors into positivity. Because if you're not learning, I mean, how do you learn? You learn from failure, you learn from mistakes. And yet, isn't that, I don't mean when you're carrying out, forgive me, Peter, but if you're a surgeon, maybe that's not going to sit quite in the way I'm describing. But it's only from other people's mistakes, if you like, or errors, that you're going to learn not to do something. And that's what we're losing through this. And where my worry might sit is that the more regulation you put about negativity, rather than learning and positivity of learning from things, you're not going to let people either flourish and grow or be innovative in ways that we absolutely need to have.
Yes, that's a very good way, I think, to wrap up this conversation, a good positive note to finish on. So thank you so much, Beatrice. You're obviously an extremely busy person, so we're really grateful to you for sparing us an hour or so of your time. That's really insightful. So thank you so much for your time and attention.